Boston at Brigham and Women's and Dana-Farber Cancer Institute. So an overview about medullary thyroid cancer, which is a less common subtype of thyroid cancer. It originates from the C cells of the thyroid gland, not the follicular, contrasted with the differentiated thyroid cancer. And the key point is that this tumor produces calcitonin, which is a hormone that's actually a very good and sensitive tumor marker. And the uniqueness with medullary thyroid cancer is that it can not only be sporadic, which is usually what's the case in differentiated thyroid cancer, but it may also commonly be hereditary and associated with what we call multiple endocrine neoplasia syndromes. And then on the right, you can see in this figure an overview of the multiple endocrine neoplasia 2A and 2B syndromes, disregard the left part of this, where the patients have a specific driver mutation that's present in the bloodstream and not only the tumor that predisposes them to develop not only medullary thyroid cancer, but also tumors in the adrenal glands, such as pheochromocytomas. And then in multiple endocrine neoplasia 2A, the patients are also at risk of developing parathyroid tumors. Moving on to discuss the higher importance in medullary thyroid cancer of genetic testing. It is standard of care to perform tumor testing for the RET gene whenever a patient is diagnosed with medullary thyroid cancer. In specific, we're looking for any activating mutations in the RET gene that you can see on the right side here in the picture, which is a receptor. There's an extra cellular domain, there's a transmembrane domain, and then there's an intracellular domain. And we can appreciate mutations or changes in the DNA that can be present spanning throughout the entire receptor. There seems to be a genotype-phenotype correlation, meaning that depending on where exactly the mutation is present, we may expect different aggressiveness in the type of medullary thyroid cancer. And then if a RET mutation is present on the tumor, it's also important for medullary thyroid cancer that patients undergo germline testing, meaning trying to identify if a RET mutation is present in all the cells of the body. And if such is the case, then we do recommend that germline RET testing following genetic counseling be offered to first-degree relatives for a patient that has proven hereditary medullary thyroid cancer, not if hereditary subtype is confirmed. And then also for parents whose infant or young children, we call those index cases, have the classic phenotype of multiple endocrine neoplasia 2B. So moving on to what are the most common presenting features. Most of the time, medullary thyroid cancer is identified because a patient presents with a lump in their neck. This is pretty much the most common manifestation of thyroid cancer overall. But then another unique feature in medullary thyroid cancer is that because it's also a neuroendocrine type of tumor, sometimes, particularly in patients that have metastatic disease, they may present with symptoms from overproducing these neuroendocrine substances. So patients may present actually with diarrhea or flushing. And then remember that there's also those hereditary syndromes that may manifest with other tumors. So it's not as common, but if a patient could potentially present with symptoms of pheochromocytoma and hypertensive crisis, or symptoms of elevated calcium levels, which can be seen in hyperparathyroidism, and then subsequently being diagnosed to have also medullary thyroid cancer in the broader spectrum of MEN2 syndrome. And then once medullary thyroid cancer is confirmed, and usually that happens after a fine needle aspiration of the suspicious lump, the next thing to perform is getting a baseline of the tumor markers, and that would be calcitonin and then CEA, which is another tumor marker. And then if the calcitonin level is not much elevated, then the only other imaging that would be indicated is a comprehensive ultrasound of the neck to understand also the lymph node mapping in preparation for surgery, which is the mainstay of treatment. But then in some rare instances, calcitonin levels may be more elevated, above 400 or 500. That would prompt us to want to make sure that we fully stage the disease and look for distant metastases that may occasionally be present. And then in that situation, we recommend performing a CAT scan of the neck and the chest, look to rule out for liver metastases with a CAT scan, a dedicated protocol for liver mets with a CAT scan, or sometimes more preferred with an MRI. But then we also in select cases consider a bone scan or an MRI of the spine. And in the next couple of slides, I put exactly the algorithm that's present in the NCCN guidelines about the diagnostic procedures and then the first-line treatment of medullary thyroid cancer. So we already went over obtaining baseline levels of calcitonin and CEA, and then if we're concerned for the presence of an MEN2 syndrome, we could either proceed with workup to rule out the presence of hyperparathyroidism and pheochromocytoma if the patient does not want to wait for the results of the RET, germline RET screening. And then following ultrasound or in select cases, cross-sectional imaging, then comes time for treatment, which is for the most part surgical. So total thyroidectomy, and then depending on each case, the surgeons may consider central or lateral neck dissection. So that's kind of the first line treatment in medullary thyroid cancer. The role of external beam radiation, it has become over the years even more conservative, and we reserve it for when tumors are very invasive and then repeated attempts of surgical resection fail to control the disease locoriginally. And then the focus of this talk is to go through the post-operative follow-up. So surgery happens, and then what? Calcitonin, as I mentioned, is a very good tumor marker. However, it stays in the system for longer time. And so we typically wait for 2 to 3 months, usually 3 months, to reassess the calcitonin levels after thyroidectomy is done. So that's what we're doing at the 3-month follow-up. So we're checking calcitonin and CEA levels. And then in terms of imaging studies, usually an ultrasound in 6 months is what most commonly happens. And then the follow-up and the surveillance after that really depends on what the findings of that post-op follow-up is. I wanted to bring 2 points that are very much different in medullary thyroid cancer as compared to differentiated thyroid cancer. There's no role to suppress your TSH levels if you've had thyroidectomy for medullary thyroid cancer. So we're aiming for TSH levels in normal range. And the other piece is that there's no role and no effectiveness from radioactive iodine in medullary thyroid cancer, and because the tumor has to do with C cells that do not take up iodine. So calcitonin and CEA 3 months after surgery is typically what we're doing. And then calcitonin is very sensitive. And in particular, we're looking for what we call the doubling time. So how quickly, if at all, calcitonin levels rise. And so if this actually is a very good prognostic feature, the calcitonin doubling time. If the doubling time is over 1 or 2 years, if the calcitonin is stable, that's actually very assuring. So then we try to space out the time intervals for surveillance. But then I also mentioned the CEA, which is another tumor marker that we assess concurrently with calcitonin. And then there are cases where calcitonin levels are low, but CEA levels are high. So this low ratio between calcitonin and CEA may be viewed as a marker of poorly differentiated disease. So that would be a sign for us to follow patients more closely. Yes.
Yes. An example. So what exactly is that? Like follow more closely, watch for metastatic. How does that characterize how my disease might behave?
So you're asking a question for someone who is already on RET inhibitors? So I would say that in isolation, it doesn't tell much, since you're already mentioning that this is a disease that's reached a point that requires systemic therapy with RET inhibitors. And there, we continue to follow calcitonin levels, so the decline or the stability in calcitonin levels, and then the cross-sectional imaging on the RET inhibitor is still used to monitor whether the systemic treatment is benefiting you. Yeah, I don't think that it plays as much role when we're already at the stage that the patient is on systemic treatment. But then it's more at that early post-op follow-up when we see patients and we're trying to understand the frequency of their interval scans, of course. And then medullary thyroid cancer can sometimes be left with persistent disease in the neck. It's not an uncommon scenario, or there can be a recurrent local disease. And then it's one of those tumors that surgical resection and removing the tumor is the preferred treatment modality when the surgeons feel that it's gonna confer oncologic benefit for the patient. I already mentioned about the role of external beam radiation that was higher up in our algorithm in the guidelines, but over the years, we have been using it way more conservatively at those high-risk patients where surgical resection multiple times for locally invasive medullary thyroid cancer seems to not longer be able to offer control of the disease. We also sometimes use external beam radiation when we have what we call oligometastatic disease, for example, disease in distant sites, and in soft tissues, for example, lymph nodes between the lungs or the liver that seem to be growing, whereas the rest of the disease may be stable. So that would be an indication for us to consider localized radiation therapy to control those specific metastases. And then medullary thyroid cancer may spread to the bones, so then and then bone metastasis may give symptoms such as pain or put the patient at risk for fracture. So for pain, we think about radiation therapy to the bone metastasis to offer what we call palliation and symptom control. And then kind of relevant to the point of having bone metastasis from medullary thyroid cancer, we're fortunate to have bone strengthening medication and bone modifying agents such as anti-resorptive treatment. Some medications that you may have heard is Zometa or Xgeva that are used for patients that have bony metastatic disease. Another common distant metastatic site for medullary thyroid cancer is the liver. And that's usually the place that leads to diarrhea as a symptom from patients with distant metastatic disease. So then again, when we have those small pockets of tumor in the liver, but the patient is not ready to be a candidate for systemic treatment, we think about local therapies in the form of radiofrequency embolization or embolization along with chemotherapy for when we have liver metastases that are focally progressing and the rest of the disease in the body is otherwise stable. But then if we're at the point that the disease is progressing in multiple sites or the patient are seriously symptomatic from the disease, and then those local approaches are not effective, that's the time to consider systemic therapy. Relevant to your point about poorly differentiated, I wanted to bring up and mention a study that was recently published. It was actually a collaborative study of 327 patients from centers in the US, but also Australia and Europe, where they looked at the histopathology under the microscope of those tumors and came up with a grading system that was two-tiered. So a tumor would be classified as either high grade versus low grade. And they had certain criteria to define high grade medullary tumors. And then in that study, 3/4 of the tumors were considered low grade, and then 1/4 represented high grade tumors. And then high grade tumors were more enriched in male population when the primary tumor was of larger size. When the post-operative CEA, that second tumor marker, was higher, when the patient was diagnosed with distant metastasis right from the get-go, or where there was a lot of invasion in the vessels on the histopathology sample. And then they've done survival analysis and found that a higher grade was associated with worse overall and progression-free survival. Coming to discuss systemic therapies for when disease is progressing, affecting multiple sites, and then local interventions are no longer enough to control the disease. The first drugs that were approved for metastatic medullary thyroid cancer and refractory to prior treatments were cabozantinib and vantetanib. These are multikinase inhibitors, but they also come with a lot of side effects just because they are affecting multiple cells, including the healthy cells of the body. But then over the years, we've been very lucky because specific inhibitors that target that oncogenic driver, which is actually very common in medullary thyroid cancer, RET inhibitors, have been developed. And since 2020, they have been approved for RET-altered medullary thyroid cancer. Remember, if a medullary tumor, it's less likely, but if it does not harbor a RET mutation, the patients would not be eligible for them. But we now have selpercatinib and pralsetinib. In fact, pralsetinib recently, the FDA withdrew the approval of pralsetinib for RET-altered medullary thyroid cancer. It had given it a conditional approval, but the company was not able to complete the expected phase 3 trial. So that led to the FDA withdrawing its approval. It has nothing to do, though, with the efficacy of the medication or the safety of the drug. So I'm posting here the several different side effects that may be associated with this medication. And then relevant to the point about how better tolerated, but also more effective the RET inhibitors are compared to the previously available drugs, cabozantinib and vandetanib, that still are good drugs, and we still use them when we have to. There was a recent randomized controlled trial where patients were randomized to either go on selpercatinib if they had a RET mutant medullary thyroid cancer versus receive either cabozantinib or vandetanib, which are the multikinase inhibitors. And the study actually showed it was done on almost 300 patients, and then the randomization was 2-to-1. So 193 patients ended up receiving selpercatinib, and 98 received either cabozantinib or vandetanib. And as you can see here, the progression-free survival was much better for those patients that were treated with a specific RET inhibitor. And on the right side of the slide, you can appreciate that the side effects were much better tolerated in those patients that received selpercatinib, leading to a much smaller percentage of patients discontinuing the drug because of the side effects. So that's encouraging and in line with what the experience of the physicians prescribing this medication has been. However, the next step and the next puzzle for us to solve is to do when the tumors start outsmarting the treatment, which unfortunately can't be seen in those patients that are on RET inhibitors. And then the tumor starts developing often new mutations that make the tumor proliferate or grow despite being on a RET inhibitor therapy. And then so far, there have been a couple major mechanisms that have been identified as potential mechanisms of resistance. And so one of them is that the tumor may develop another mutation in the RET gene, the V805M, which is also considered a gatekeeper mutation. So essentially what that does is that this mutation blocks the multikinase inhibitor from binding and exerting its effect into blocking the tumor growth. And then the other thing that we sometimes observe is that the tumors accumulate another type of mutation, usually a RAS mutation, that still will allow the kinase inhibitor to still bind and exert its effect on that end. But then we also have an aberrant RAS signaling that's going to lead to tumor growth. And we're at the point that we're trying to come up with strategies to try to overcome this resistance. And then there's an active clinical trial, it's LOXO 260, for those patients that do have a RET-altered solid cancer. So it's actually not specific to medullary thyroid cancer only, who have received one prior RET inhibitor to try to see whether that will help overcome the resistance. So these were the slides that I've prepared for you, but I mean, definitely I'd love to answer any other questions. And thank you for listening. Yes.
Yeah, thanks for answering the question about the Ki-67. So just one last follow-up, and we could take this offline if it's better to talk about, not waste everybody's time, but you know, with requiring a lot of follow-up and a lot of scans, even being on the systemic treatment, I do wonder about what is my total dose of radiation from all the scans, and do I need to balance that with the doctor's desire to keep a close eye on things as a patient? I do not have a good understanding of how much radiation I have received and what risk of secondary cancer I have from those scans. So I'm told that the new CTs don't have that much radiation, but I think the dotatate is a significant amount. And so I don't feel like I have enough information as a patient to be able to make an informed decision. And when I ask how much radiation will I get from this scan, oh, you can ask this person, and they say, oh, you have to ask the
Radiology.
the physicists.
Yeah.
And here's an email that nobody will ever return.
Right.
You know, so nobody actually knows, or nobody will tell me.
Yeah.
Over.
So you're asking a very good question, and then this is an issue particularly for those younger patients when we know that we expect them to do very well with RET inhibitors, but we're also concerned because we are dealing with an aggressive cancer that requires systemic treatment. There's no right or wrong answer into how frequently those scans would be made. I would say that every 3 or 4 months is very typical for those patients that are on systemic treatment.
So at this pace of scans with the CT scan every 3 or 4 months, what risk do I accumulate over time for secondary cancer from the radiation?
I don't think that I have an answer for you, unfortunately. However, the more exposure to have the CAT scan, the theoretical risk is there. And then low dose CTs and speaking with radiology mainly to protocol the scans in a way to minimize the risk of radiation is probably the best balance between exposing you to the risk, but also making sure that we have the answers needed to continue the treatment. And then also as a provider, we ask ourselves, what are the information that we get from the scans? Both the PET-CT and the dotatate are scans that do expose you to radiation, but then, so these would not be our typical scans that we perform every 3 months, for example. So these are reserved when we're trying to ask specific questions. Let's say we do cross-sectional imaging, CEAs going up, but we're not seeing anything on the CAT scan. Could the PET-CT or a dotatate give us more information? That's more of the scenario where we use them.
It says, for monitoring for recurrence and metastasis, what alternative biomarkers do you suggest when calcitonin, CEA, and procalcitonin were all non-detect while the tumor was still present? Sporadic 2.6 centimeter tumor did not stain positive for calcitonin, so is being considered a non-secretory MCT. Okay. Yeah.
So in terms of biochemistry, the tumor markers that we have available are calcitonin and CEA. And then if none of them is detectable, however, disease is present, then cross-sectional imaging would be the mainstay of disease monitoring, the best tool that we would have available. And then we also now have liquid biopsies or circulating tumor DNA, where we're trying to understand if there's tumor shedding in the bloodstream that has certain mutations, certain changes in the DNA that we might be able to pick up. So the only other thing that I could think of is doing a liquid biopsy, seeing whether there's a specific mutation driving this tumor, and then monitoring that with what we call circulating tumor DNA.
What could be used in non-RET patients when cancer progresses and when Cabo stops working?
So vantetanib as an alternative of cabozantinib. And then after that, thinking about participation in clinical trials.
Is it true that soaking in an Epsom salt bath helps remove radiation after scans?
I don't think so.
What is your approach for non-RET patients with KRAS mutation with progression while on Cabo?
I think if they've not been exposed to vantetanib, we would think about vantetanib instead of cabozantinib and seeing whether it confers benefit. They do have slightly, they do have differences in their side effect profile. We think about the side effect profile and whether it would be limiting for the patients.
And last question on the Zoom that I have right now. Can taking a break on selpercatinib cause progression? How long is a break if you have an operation on another cause?
If you have a what?
It's how long is a break if you have an operation on another cause?
Yeah, so because these medications also affect the healing process. We may interrupt them, for example, for a surgical procedure to happen, and then a small break around the procedure should not really have a major impact on the disease. But then longer breaks are more under discussion, and then that's when a discussion between the patient and the provider needs to happen to understand risks, benefits from that break.
Okay. If tumor testing with Foundation One yielded a result of undetectable mutation, do you suggest testing with another company? How unusual is it to have an undetectable mutation?
Yeah, so it can happen, and there's a difference between the type of testing. So it's a different thing to do liquid biopsy. So that's when you're trying to search for tumor cells that are shedded in the bloodstream from the tumor, and you're trying to pick up those mutations versus doing the testing on the actual tumor sample, which is the gold standard approach. So whenever we have to pick, we always want to test the tumor itself. And then if there's occasions that you may have a primary tumor and then you have a recurrence several years afterwards in a distant metastatic site, the sampling the distant metastatic site is expected to give you the most genomic information and the most aggressive, possibly the most aggressive mutations that are driving the tumor.
What additional biomechanical or biochemical testing is appropriate for bone mets surveillance?
Yeah, so for bone metastasis, we think about bone health overall. So making sure that calcium levels, phosphorus levels, those elements that build the bone, vitamin D levels need to be intact. There's also markers of bone turnover that may occasionally be assessed. But for the most part, the calcium and the vitamin D are the big players in keeping bones healthy to the extent they can be.
I have a question about doubling time. At surgery, first surgery, calcitonin was 500. They didn't know he had medullary until after the surgery, but I'm assuming a day or two after it was about 500. Second surgery removed lymph nodes. It went down to 22. That was 12 years ago, and it's up to 134. Is that a doubling time when you have low numbers as opposed to someone who went from, I don't know, 1,000 to 2,000? Is it a different sign?
So very good
The
question.
CEA is always been low, 1.1.
So very good question. So when we talk about doubling time, we don't compare the preoperative calcitonin, right? So this gives us more of an overall baseline. But then when I'm talking about doubling time, let's say you do your 3-month or your 6-month follow-up, and the calcitonin is 22. And then if 9 months later, calcitonin goes to 1,000, that's concerning. But then if at 3 months it's 22, and then in 9 months it's 50, that's a different scenario that speaks for a slower growth process. And then if you think about years, I don't think that it's applicable to talk about doubling time. So we usually measure it more frequently, let's say every 6 months.
Better measurement with someone who has a low calcitonin and a low CEA to really look at what the node or the few things that get picked up as a couple of centimeters, it's 2 centimeters or 3 centimeters. Is that a better measurement of disease progression than just a calcitonin that kind of slowly is rising year by year, 5 or 10 points?
Right. So if all you have is a calcitonin level that's slowly rising, but then you see nothing on the scans, that's a different scenario. But then if you observe your calcitonin levels and then you do an ultrasound and you identify a clearly abnormal lymph node that a surgeon can take out, then the imaging trumpets the blood test, right? Because you have a target that the surgeon, if a surgeon thinks that it's removable, it's resectable, that's what should happen, regardless of what happens with calcitonin itself.
So my question was, for patients that have started a RET inhibitor, is there like an estimated median value that you would see when they start developing a new mutation? I mean, do you see it at any typical time, or does it just vary like every, after 2 years of starting or 10 years or?
It varies for each patient. And
Okay.
as you can see here, the progression-free survivals here, for example, have been measured up to 13 months. So we're talking about almost 3 years on the drugs, and then the patient continue on being progression-free at almost an 80% for yellow line,
Oh,
right? But then clues for that would be seeing what happens to the calcitonin, seeing what happens to the CA, whether we see a gradual uptick, like a one-time blip of calcitonin going up would not suffice, but then if we see this slow trend of calcitonin levels going up. Right. So the ways of doing disease monitoring for someone who is on a RET inhibitor includes both biochemistry with calcitonin and CA, but also scans. And then yes.
So, because of how much calcium I take every day, I've had kidney stones, because of that. So I'm just wondering, like, how often should I get my calcium checked to make sure I don't get kidney stones?
Right. And then an issue with patients that have undergone extensive neck surgery, whether it's for differentiated or medullary thyroid cancer, is that it may damage with repeated surgeries that they're at risk of harming the parathyroid glands. Then patients need to stay on calcium supplementation, frequently on calcitriol supplementation to make sure that they retain the calcium. So there's a delicate balance between maintaining calcium levels in the blood in the low normal range and then avoiding the excess peeing out of the calcium from the kidneys. So the goal for that would be to maintain a healthy calcium intake of about 1,000 to 1,200 milligrams of elemental calcium, either from diet or supplements as needed. But then the goal would be to maintain calcium levels in the low normal range, so not overdo it or not aim for fully normal calcium levels, and then titrate the calcitriol so that the risk of hypercalciuria, which means excessive calcium excretion, is not there. And then sometimes we may need to use additional medications such as water pills that help reduce this excessive excretion of calcium that eventually leads to stones, kidney stones formation. Okay. There's no other questions. Thank you so much for attending. Oh, there is one more. Oh. Wait. No.
I understood there might be a correlation with Retevmo and people trying to convert T4 over to T3 because of the L1, L2, and L3.
That's the deiodinases. So in the thyroid gland makes thyroid hormone thyroxine, the T4. And then we have enzymes in our body, in every cell of the body, that convert the T4 to the active form of thyroid hormone, which is the T3. And this is facilitated by 3 different enzymes, and then some activate it, some block it. So it seems that there's a discrepancy between how these two hormones, the T4 to T3, are metabolized. The hormone that really acts on the receptor of thyroid hormones is the T3. And then ultimately, what we assess whether the thyroid hormone supplementation that we give is sufficient or not by checking the TSH level, because that's the hormone in the pituitary, in the brain, that regulates all the thyroid hormones in our body.
So I'm sort of gathering, but I have ascites and pulmonary. And I kind of understood that T3 could also be part of that. Part of causing that?
So TSH is our marker to tell whether. Yeah, so if you have hypothyroidism and then you don't have enough thyroid hormone levels in your body, that would reflect with an elevation in your TSH level. And then if you have too much of TSH, so meaning you're hypothyroid, this can make the water retention. This can make you more prone to water retention. So that's why we aim for TSH levels at normal range. So that's our marker to understand if you need more or less of levothyroxine.
TSH is one.
Yeah, so a TSH of 1.0 would, right, on replacement, right? So this would signal that there's enough of thyroid hormone levels in the body. That said, separate to the ascites question, I don't think that we have a very strong call on whether it's related, and I would think less likely with a TSH of 1. Outside of that, there are patients that may not feel well on levothyroxine alone, and a select group of them may do better with a combination of levothyroxine with Cytomel, which is the active T3. But I would expect this to have a major impact on the fluid retention.
I think that in the Retevmo study, the lung cancer, people on it for lung cancer, and they didn't have their thyroids from the had a different outcome than we
Medullary.
Retevmo. So
Right.
seems something going on there with, yeah.
The big difference is that for
And
medullary,
adverse
most of
thyroid
them, yeah, for most people, most of the patients have had their thyroid removed. So then they depend on the outside levothyroxine. I would think that maybe that's one of the reasons. Okay. Thank you very much.